Good evening, everyone. I welcome you all to 17th webinar of Society for Pediatric Cell Therapy and Transplant. And today we have an interesting topic lined up: acute myeloid leukemia and transplant. With some great speakers and moderators and panelists who are logged in today. So, I believe you should really benefit. AML is a challenging disease in our practice as transplanters. And first is the challenge of getting them into remission, then making them reach transplant, and then have enough funds so that they can undergo transplant. So, it's a huge challenge in India to make this happen, but it is happening, and a lot of centers are doing some good work. So let's see how our speaker gives a perspective of global perspective, how things are, and how best we can treat AML in India. So today we have, uh, can we show the first slide, please? Yeah. So for this webinar, we have sponsors. The sponsor slides would come just now.
Or should I stop
Yeah,
sharing?
stop sharing. Yeah, yeah. Please
Okay.
stop sharing.
Okay.
Yeah, yeah. So Jolly, can you put the slide?
Jolly?
Yeah. So by the time that we have a slide on, I will introduce the chairperson for today's session. So we have none other than Dr. Neeta Radhakrishnan, who is additional professor of pediatric hematology oncology at Child PGI Hospital in Noida. She's heading the department, and she has been a very senior member of PHO chapter, like secretary of PHO chapter previously, and doing commendable work in the field of pediatric hematology, oncology, and bone marrow transplant. Recently, I believe they have completed 100 transplants in their center. So I congratulate her for that also. So over to Dr. Neeta to introduce the speaker and take the session forward. Thank you, Dr. Neeta.
Thank you, sir. So good evening to all of you who have joined in from India, and good morning and good afternoon to the others. So we have a very exciting session coming up, and our speaker is Dr. Ravi Shah. He's a pediatric oncologist and cell therapy physician from Alberta Children's Hospital, and he holds an academic position at the University of Calgary in Canada. He also serves as a fact inspector. His research interests are pediatric leukemias, aplastic anemias, haploid integral stem cell transplant platforms, and chronic GVHD. So I think I can hand it over to you, Dr. Shah, for your deliberations. And after this, we'll have a panel discussion. I'll introduce the moderator and panelists at that point of time. And thank you to SPCTT for this invitation, and looking forward to a great discussion today. Over to you, Dr. Shah.
Thank you, Dr. Neeta, for kind introduction. I will share my slide. First of all, thank you, Dr. Kateva. I don't see him, probably he's there somewhere, for this opportunity and to talk to this great group of people who, some of whom I met this year in the SPCTT meeting, and it is great opportunity to learn from each other, and I hope I do justice to your time. So we are going to talk about pediatric AML and HSCT. This is one of the most complex transplants as a transplanters do, because these are generally difficult to treat leukemias compared to other type of leukemia we treat. Okay, can you see my slides?
Yes, yes.
Yeah, sorry. Okay, so yeah, I do not have any conflict of interest. My talk may involve off-label use of drugs. And full disclosure, I read more about geography and history of this region over last week compared to acute myeloid leukemia with the global events going on. Okay, so the objectives of my talk will be indications for HSCT in children with acute myeloid leukemia, prognostic factors in children undergoing transplant for AML, conditioning regimens for children with AML, role of total body irradiation in transplant conditioning, role of transplant in refractory AML, and role of post-transplant strategies to improve the leukemia-free survival. Um, each objective is probably 1 hour talk in itself, and it is difficult to cover each objective in depth in this 45-minute talk, but I will highlight important issues, and I will highlight important evolution in understanding of transplant and factors affecting it in children with AML. As we all know, the prognosis has generally improved in recent decades, with current overall survival rates approximately 60 to 70%. This is mainly because of risk stratified therapy. We are better able to define patients with high risk group, high risk features based on cytogenetics and molecular features, as well as response to therapy. Targeted treatments like FLT3 inhibitors, gemtuzumab, and menin inhibitors are commonly used. May not be accessible everywhere, but at least it is increasingly being used. Relapse in acute myeloid leukemia of childhood remains a challenge, and despite intensive regimens and risk stratified therapy, um, th- uh, this is the challenging area of oncology. HSCT is the only curative option for those with relapsed or refractory acute myeloid leukemia. Although the advanced cellular therapy like CAR T cell therapy or bispecific antibodies are currently under research but not in mainstream. Just brief about treatment targets currently available or under development in children or adults with acute myeloid leukemia. The one with the arrow we are currently using. Donor lymphocyte infusion, which generally we are using non-targeted. FLT3 inhibitors, venetoclax, which is BCL2 inhibitor. IDH1 inhibitors, IDH2 inhibitors, although this is extremely rare in children, mainly adults, but we have patient on this and has done remarkably well, although not in complete remission, but it does prolong the survival. Revumenib, which is menin inhibitor recently approved for children with leukemia with KMT2A rearrangement. Hypomethylating agents, and last but not the least is gemtuzumab, which is now used at least during the induction in North American setting. It is not used in consolidation because both NOFO and some other studies have showed that using gemtuzumab in consolidation does not add any benefit. What we know. So I hope most of you or all of you will be agree with these statements. So this is the current understanding is that cytogenetic and molecular markers not only help prognosticate the disease, but defines or has a huge role to play in HSCT indication. For relapsed AML, reinduction regimens have not improved much, but access to transplant has significantly improved, and that is the main reason the outcomes are better now, mainly because of the Haplo platforms. Choice of conditioning regimens plays a major role in outcomes. Haplodonor graft gives comparable outcomes to HLA match donor grafts. This is overall picture. There may be subgroups where you would prefer some one over the other. Graft versus leukemia effect has a greater role to play in children with AML compared to ALL undergoing transplant. And pre-HSCT MRD or remission status before transplant is a significant prognostic factor. So this is a nice diagram showing how the cytogenetics or molecular risk groups have evolved over time. So this is the COG practice, and you see in the POG group, there were only 5 high-risk cytogenetics subgroup, and then subsequently more started to get added, FLT3 and then NPM1 mutations, CBPA mutations, and then now the list is long. In fact, with new COG classification or reclassification, 24% patients who were classified as um, standard risk or low risk, they were reclassified as a high risk because more molecular and cytogenetics understanding came into picture. So what we do not know or not sure about. So what is the optimal donor choice? So when we have all the donor options available, whom to choose? What is the optimal haplotransplant platform? Then second is which is currently a question. Lots of debate going on. What is the best conditioning regimen? Because now you, as the conditioning regimens improved over time, and also pharmacokinetics came into picture. How to condition these patients optimally? Incorporation of plerixafor and GCSF in the conditioning. So there is hypothesis that use of these agents result in better myeloablation by during the conditioning. Novel agents and incorporation into conditioning. And when patient relapses, what is the optimal reinduction regimen? So FLAG is the was the de facto reinduction regimen, but now people are increasingly using different reinduction regimen. So in patients with refractory AML, what is the role of bridging therapy? An indication role of prophylactic DLI and post-transplant maintenance. So again, this is each of this heading and sub heading are a talk in itself. So the current indication of transplant in children with AML. So this is a COG practice, and I think it aligns well with global practice. And I would like to know the view of my Indian friends and colleagues. What is your current practice? So any high risk, any patient with high risk cytogenetics and molecular profile, there is a transplant indication irrespective of MRD. So in AML, COG 1031, 30% of patients were classified as high risk, but now with newer classification, it is 40%. So more abnormalities are included in the high risk profile. Any AML with myelodysplasia related changes are transplant indication. Presence of RAM LAIP. So this is interesting, was discovered in one of the COG studies 2018. They found that this particular immunophenotype have poor outcome and benefits from transplant. End of induction MRD more or equal to 0.05% without favorable cytogenetics or unfavorable cytogenetics. So this is the current indication. In the past, it was 0.1%, but now it is 0.05%. End of induction blast more than 5%, that is induction failure, that is indication for transplant. End of induction 2 MRD, although this is not currently included in the COG indication, but this is generally being practiced that anybody with good risk cytogenetics, we tolerate end of induction 1 MRD, but end of induction 2 MRD, we offer transplant or at least discuss transplant. But it will be interesting to see those data once it comes up. Treatment-related AML, secondary AML, and relapse AML obviously are the indication for transplant. So this is the huge list of cytogenetics abnormality, which some of the fusion partners, etc. As a physician, I cannot remember everything. So it is good to always go back to the protocol or go back to the list and classify patients. For example, patient with FLT3 ITD, in the past it was the allelic ratio of 0.4% was high risk, but now they have lowered it to 0.1%. But they put a caveat that it has to be without biallelic ZIP CBPA mutation or NPM mutation. or if they have mutation, then you have to have MRD positive. So automatically it does not define transplant FLT3 positivity, but you have to look at the other associated markers. And for example, KMT2 rearrangement, you have to look at the partner, and if you have the RNA-seq, look at the fusion genes. So this is very interesting area of evolution in transplant for AML, because it defines transplant indication even if you are MRD negative. There are certain subgroup where transplant may not work, and I will highlight that. So COG over last a decade ran 3 trials. So currently it is the AML 1831. So they combined the previous 2 trial data and analyzed together, and they reclassify some patients in high group. So they clearly demonstrated that patients in high group, as per the current COG classification, if you do transplant in CR1, the 5-year disease-free survival is significantly better compared to those who do not undergo transplant in CR1. So as you can see, the p-value less than 0.001. So this is high risk subgroup. So 50% disease-free survival and overall survival 58%. Similarly, in those with standard risk AML, but with MRD positive only, the transplant does offer benefit, about 50% disease-free survival compared to 16% in those getting chemo only. However, it is not as a strong benefit as you see in patients with high-risk cytogenetic subgroup. In multivariate analysis, in those with high-risk AML, those getting transplant in CR1 was the only prognostic factor. So here, most patients underwent transplant after 3 cycles of the initial chemotherapies after intensification 1. In subgroup analysis, they showed that transplant did not benefit those with monosomy 7, monosomy 5, or deletion 5q. It was interesting observation, but we'll see if addition of gemtuzumab in the induction changes this outcome. Excuse me. So I do not have to go through this each and every factor in detail, but the most important factor affecting transplant outcome currently is disease status before transplant. Of course, this gets affected by cytogenetics and molecular subgroup. Choice of conditioning regimen, and graft versus leukemia or graft versus host disease. Graft versus leukemia effect post-transplant. Surrogate marker is your GVHD. One factor which has not been well studied is time to transplant, and as we know that patients accumulate toxicity over time on chemotherapy, and there are some belief that in those with high risk cytogenetics, why do we give 3 cycles of chemotherapy? Just go to transplant after 2 cycles. Another, there are some abstracts that in adults mainly that delay in transplant after achieving CR affects the outcome negatively. Switching the gears, so we talked about transplant indications and overall factors affecting the transplant outcome. So now talking about the conditioning. This is the evolution of conditioning regimen. So in 1970s, single dose unfractionated TBI was used. Now we don't use TBI anymore, and I'll go through that again. And fractionated TBI 1982, oral busulfan with Psi, then busulfan with reduced dose of Psi, 120 milligram per kilo, then IV busulfan and cyclophosphamide in early 2000s, and then addition of MEL in BuPsi or BuMel without Psi. Then Trio came into picture in mid 2010s, and now it is increasingly being used, and I'll highlight that. So currently Europeans are studying Bufluclo versus BuCimab. Okay, so This is the intensity of conditioning regimen. Based on that, many practicing transplanters choose regimen for that patient. Of course, you have to look at patient's morbidity and overall health status to choose those. But generally speaking, most physician in North America or Europe prefer to go full myeloablative for patients with AML. So choosing BU-based regimen. Um, is, you know all this, but one important point I want to highlight is obtaining the targeted BU AUC via IV route is fundamental to achieving therapeutic goal, which is myeloablation, and avoid toxicity. As we have seen repeatedly in many studies, not only in AML, but even in recent forum trial, they did the subgroup analysis in children undergoing transplant with ALL. And although the overall trial showed TBI is the beneficial one, when they did subgroup analysis, when they accounted for the busulfan area under curve, the benefit of TBI disappears. So I think that remains most important factor when you are using the busulfan based regimen. The targets of busulfan varies depending on what other agent you are using along with. When you add melphalan or clofarabine along with buflu or busi, the AUC is slightly lower compared to when you use bu with fludarabine, for example. So generally, AUC target help you to achieve a desired effect with, and it also ensures that undue or toxicity, mainly VOD or SOS, patient is not at very high risk of. So we talked about the evolution of transplant conditioning regimen. So TBI was commonly used in any type of leukemia as a transplant conditioning regimen, but now for AML it is not used commonly, although it is the sometimes physician preference, and sometimes for resistant cases people still prefer the TBI. This is a picture of child who received first radiation therapy for retinoblastoma. Subsequently, the role of TBI has evolved, and subsequently, role of radiation has evolved, and then for transplant in 1970s, total body irradiation started to being used. In adults, initially showed that there is no benefit of doing a full dose TBI based regimen in adults with acute myeloid leukemia. This was quite interesting study, and they clearly showed that IV busulfan was the best way to use busulfan. IV route is the best way to use busulfan, and when compared with TBI, busulfan based regimen had better outcomes. Children, similar CIBMTR registry data showed that overall survival did not differ between TBI and non-TBI, but TBI did have benefit in reducing the relapse risk. However, TBI increased the risk of non-relapse mortality. Japanese registry data, which is more homogeneous data compared to CIBMTR, they clearly showed that there is no benefit of TBI-based regimen over busulfan-based regimen, and they only included IV busulfan-based regimen. And this was interesting because what they thought that IV BU psi will be better than TBI, but they did not find it in their study. So their hypothesis was maybe we included many patients with relapse and NCR2, and that's why we did not see the benefit. Interestingly, no difference in acute or chronic GVHD. Again, large EBMT registry data convincingly showed that no benefit of TBI based conditioning regimen, myeloablative conditioning regimen in improvement in leukemia free survival. So The hard black curve is TBI-Psi. The dots are Bu-Psi-Mel, and the dash curve is Bu-Psi. So the best regimen in this study, large EBMT registry study, was Bu-Psi-Mel. The relapse incidence was with Bu-Psi-Mel is about 14.7%, which is remarkable considering this was a registry study, quite large number of institutions and large number of patients were included. So this remains one of the benchmark of to use or like to um, argue for using a full myeloablative conditioning regimen. Interestingly, many patients in this study did not have targeted BU or there was no subgroup analysis targeted or not targeted, but it was it was compared with another arm which also did not get targeted BU. So non-relapse mortality was also not different as it was shown in CIBMTR. There was slightly higher non-relapse mortality in TBI group, but here there was no difference. In multivariate analysis, Bu-Psi-Mel was the only significant factor in reducing the relapse risk. Yeah, the protective is using Bu-Psi-Mel or three alkylators was protective, so decreased odds of relapse. So older age at transplant, a longer gap between diagnosis and transplant, and occurrence of PBSC use of PBSC was associated with higher non-relapse mortality. Bu-Psi-Mel as one would imagine that higher risk of VOD, but they did not show significantly higher risk of VOD or other toxicities. So well-tolerated regimen. I would be interesting to hear your views in your Indian settings. Yeah. So can flu replace Psi? So this is currently what we do in our institution. We don't use Psi. We just do Bu-Flu-Mel. But yeah, so why there is more interest in replacing Psi? Because cyclophosphamide contributes to toxicity, increased VOD risk, increased hemorrhagic cystitis, and mucositis. These patients, when they get Psi with Bu, it is quite toxic regimen. So flu does not cause GST depletion. So glutathione transferase, one of the enzymes, metabolic enzyme in liver, and that helps avoid some of the toxicities. And combination is synergistic. There is a study, Bartling et al., Boland's group. They studied flu versus Bu-Psi or Bu-Psi-Mel, and they clearly showed that the efficacy is same, but less toxic and less virus infection, flu-Bu. So as I mentioned earlier, the NOFO group is currently studying Clo-Flu-Bu versus Bu-Psi-Mel. I wonder why they did not do Bu-Flu-Mel, but and that was one of the reasons we did not want to be part of this study we were discussing. The flu dosing is variable among different protocols, so especially for trainees, pay attention to when you read the literature, what is the flu dosing, what is the Bu dosing, what is the Mel dosing. All protocols have slight variation. Depending on that, you may have different outcomes. For example, Calgary protocol, we use Bu-Flu. So we don't use fully myeloablative target of Bu in this protocol, but we add 4-grade TBI. So our adults use this regimen for last 20 years, and they have shown remarkable outcomes. Because it is very less toxic and the adults tolerate it very well. But they use quite high dose of flu in their protocol, so total 250 milligram per meter square. This is one of the abstracts submitted, published from NOFO group. Sorry for the hazy picture, but yeah, so they showed that Bu-Psi-Mel versus Clo-Flu-Bu, there was not much difference. But Bu-Psi was the worst for leukemia-free survival compared to these two. And TRM trend was slightly higher with Bu-Psi-Mel. Now, the flavor of the current transplant practice, triosulfan. So triosulfan was have been used in India, Europe for longer period than North America. As in Canada, we have been using for the last 7-8 years or 10 years almost. But in US, it is only started being used because it only recently got approved. Maybe that is the reason we don't have many studies supporting triosulfan, but these are some of the studies. So mainly it is used as a myeloablative or reduced toxicity conditioning regimen, mainly used with fludarabine and thiotaba. And you can see the disease-free survival in this using triosulfan based regimen is acceptable and it is good. So especially the UK study showed 79% disease-free survival at 3 years with non-relapse mortality of 17%. Chronic GVHD rates are higher, may reflect some of this patient did not have enough serotherapy use. And the latest publication is from Poland. They have used this in 85 patients and they showed a DFS of 71%, still lower than DFS of more than 80% in the study shown by EBMT. So it is slightly lower than what BuSci-MEL offers, but it is still acceptable because the toxicity is much less and again long-term outcomes I'm not including in this talk, but there are lots of focus on long-term outcome, especially for pediatric nowadays. Yes. Role of serotherapy. So generally for match sibling donor or match related donor transplant, we don't use it. Umbilical cord donor transplant, we do not use it. Some people still use it. We do not use it. For MUD or mismatch unrelated donor transplant, rabbit ATG is commonly used. The dose and timing is increasingly being recognized. So trainees especially must read some of the papers by Admiral et al. Quite fascinating that rabbit ATG has been used for such a long time, but now we are learning about its role in transplant outcomes, not only for GVHD, but leukemia-free survival. For haplo PTCI, rabbit ATG can be added. There is some benefit, but significant increased risk of viral infection, so we do not add it. TC alpha beta low dose ATG is used, and timing and dose vary among studies and need to be investigated further. So when to consider, so we talked about myeloablative transplant. I have not talked about reduced intensity transplant. So some of in this group who are listening might be doing adult transplants also, and um, there the reduced intensity conditioning is commonly used, especially the John Hopkins regimen with PTCI. However, in children, um, we prefer the myeloablative regimen because children tolerate conditioning better. However, in those children with poor tolerance to chemo or with serious persistent organ damage or infection, you could consider reduced intensity conditioning. With overall improvement in supportive care and transplant regimen, the TRM is low even with myeloablative regimen. And generally, it is less than 10%, at least in the Western setting. So MAC still is a preferred regimen, but RIC should be considered in certain patients like on the slide. Refractory patients, definitely there is a role of cytoreductive chemo as a bridge to transplant, for example, Flamza, clofarabine, etc. Those with high risk of transplant toxicities, Down syndrome, Fanconi anemia, leukemia predisposition syndrome, or RIC can be considered. The sequential conditioning regimen, nowadays people using those with refractory AML. We use one with clofarabine bridge. However, clofarabine excess is an issue. It is a costly drug. So Flamza is another regimen, but it is more toxic and more historic, especially for pediatric. I don't know what is how many people are using Flamza anymore. So haplo. So you this group does more haplo than mm, most people around the world. So m- this platforms better than some of this platform better than even I do. So I feel that Haplo has definitely changed the game in patients with AML because access to transplant has significantly improved. These are different platforms. You can read from references. Um, but there are certain principles. For example, in those with MRD positive or those with refractory AML, T deplete transplant or T cell alpha beta depleted, people don't like because they want that immediate graft versus leukemia effect. So on and so forth. Beijing protocol probably gives best graft versus of leukemia effect, but highest risk of acute and chronic GVHD because they don't use PTCy, but still use haplo donor. Um, So EBMT did a match pair analysis of MUD and haplo and convincingly showed that there is no difference in the outcome. There is slightly higher risk of acute GVHD in haplo platform, but generally majority of patients had comparable outcomes to MUD. One of the conclusion of interpretation of this is don't wait to find match donor. Um, um, and majority of patient had a PTCy haplo in this analysis. So what we do in Calgary, so we have recently changed our protocol to use Bu-flu mel in our patients. Um, this is one of the group in Arizona uses this protocol. They have showed that when you use Buflumel, the outcomes are good, especially use haplo donor. So here, the advantage of this regimen is Bu target is much lower than you would use in Bucimel or Buflumel. So haplo Buflumel, the GVHD-free relapse-free survival is about 80%, so which is remarkable. So we currently use that this regimen. TC alpha beta haplo. So Italian group clearly showed that it does work in both LL and ML, and but one of the negative prognostic factor is the MRD positivity before transplant. Even in this paper, they showed that no role of TBI for AML, but for ALL, there was a clear role of TBI in patients undergoing TC alpha beta haplo. So mainly they use BU-based conditioning in this paper, a large number of patients. ATG exposure, I think I highlighted this when I gave talk to the SPCTT that now we are trying to understand, trying to learn or like coming to know the importance of ATG. The DFS by ATG exposure is significantly different among patients. And as you can see, even in those with MRD positivity, if you have optimal ATG exposure, the outcomes are good. So I think more research will come on ATG moving forward. A word about umbilical cord. Now not commonly used because of haplo access and cost. Even in North America, it is not commonly used nowadays. However, it is an important option because it does give access to immediate transplant and great graft versus leukemia effect with without increased risk of GVHD or chronic GVHD. Uh, so this was from UK group. They showed that T replete code means they did not use serotherapy was better outcome compared to those with undergoing transplant with massive sibling or MUD historical comparator arm. And this was patients with MRD positivity. Why umbilical cord may have a edge? Because these are T-replete, this is T-replete graft, and There is ontogeny difference between umbilical cord and mature donor graft. So it is more fetal phenotype. So when these T cells expand or it has been shown to undergo rapid CD4 T cell biased expansion, thymus independent, compared to CD8 plus biased expansion you see in mature donor graft. So, and of course, we know this chronic GVHD risk is lower. So role of KIR favorability, I will not go into detail, but bottom line is there is no convincing evidence that for use of this in mainstream. Mainly people think this it might have a role in TC alpha beta haplo because in TC alpha beta haplo, your NK cells are preserved in the donor graft. So you want to harness the graft versus leukemia effect of the NK cells. Compared to PTCy platform, um, your cyclophosphamide is going to kill your NK cells. So there, I don't know even if people are studying that question in PTCy platform, but it will be difficult to biology doesn't tell that you can harness that GVL effect because your high dose cyclophosphamide is going to affect your NK cell negatively for many months after the cyclophosphamide dose is given. Um, Choosing the donor or graft source. So apart from routine donor selection criteria, um, please let me know if I need to stop and finish. How much time do I have?
You still have 4 minutes, Ravi. Don't worry.
Okay, okay. So choosing the donor and graft source, so consider remission status and timing of transplant and cost definitely. Do not delay transplant waiting to find a good donor. Nowadays, donor, as long as you have good donor available, doesn't matter it is match donor, flow donor, unrelated donor, etc. Prefer marrow in those with CR because lower risk of chronic GVHD. Those with refractory AML or those with persistent MRD, choose T-replet, haplo, or umbilical cord. KIL ligand mismatch, not enough evidence to recommend practice currently. Prognostic factors, I'll not go into detail, but relapse AML is a definite indication of transplants. The main prognostic factor, apart from the cytogenetics, etc., is achievement of the CR2 or MRD negative before second transplant. Relapse within 1 year, as is negative BFM study showed that relapse within 1 year affects the transplant outcome negatively. But if it is late relapse more than 1 year, the overall survival is good. One question repeatedly come up is should children with more than 5% blast or those with M2 marrow or M3 marrow should undergo transplant or not? Miss BFM study showed that there is some benefit of doing transplant. This patient overall survival 27%. But the most important, most interesting outcome were published by Chinese group Beijing protocol using Beijing protocol. So what they did was they used a haploidentical transplant without PTCy with intensified conditioning, and they clearly showed that the leukemia-free survival was good. And some of these patients had M2, M3 marrow. And as you can see, compared to the match donor transplant, um, obviously the chronic GVHD risk was very high. Chronic GVHD outcomes were negative. So about 70% patients in the haplo group developed chronic GVHD, but the leukemia-free survival was significantly better. So it just teaches us that graft versus leukemia plays a huge role in those with resistant disease or MRD positivity. So in those with refractory AML, cytoreductive chemo should be offered or considered. Try to achieve CR or at least M1 marrow, because the Chinese group clearly showed that those who have more than 50% reduction in the blast, they have better outcomes. Use a T-replet donor to harness the augmented GVL effect, especially if you use haplo donor, and consider use of DLI. This is very important, especially resource constraint settings. You have to manage expectation of families because families are spending fortune or uh, and many times their expectations are high. If patient has refractory AML and you're offering transplant, so counseling is very important. Strategies post-transplant, I will not go into detail because of the time constraints, and we can talk in the panel discussion. But I hope I have highlighted some of the themes in transplant for AML, some of the evolving ideas, where the world is going, and I hope I'm sure you have many questions, but the main conclusion is one size no longer fits all. So it is moving towards personalized medicine. Thank you.
Thank you. Thank you, Dr. Ravi. So I think there's a question in the chat. Can we take that, Sunil, before we go to the panel?
Yeah, that should be fine. I think we can take few questions now.
So question from Dr. Preeti. So what you don't use ATG in MST. So what is your incidence and the grade of GVHT in your cohort?
That's great question. So one thing is we do not have enough patient with massive donor to publish that, but generally, if you use marrow and cyclosporin plus methotrexate prophylaxis post-transplant, you do not need ATG. That is the general understanding. Of course, if you use ATG, it may not affect your transplant outcome negatively, or but the risk is still low. The chronic GVHD risk is low. I would say less than severe chronic GVHD less than 15%, which is acceptable range. Yeah.
I think Dr. Yadav has a question.
Yeah. Uh, Ravi, a very informative and crisp talk. Thank you. So I have the eternal question which most transplanters and most of the trainees would like to ask you is that you have done a transplant for AML patient. When and how to use DLI, donor lymphocyte infusions, in these patients after transplant? Thank you.
Sir, I think I have that question in my panel discussion. We'll be discussing in detail.
Okay.
Okay, then maybe a brief. What is your practice? Maybe you can tell that.
So right now our practice is using preemptive DLI. So those with early MRD positivity or with falling T cell chimerism, we offer preemptive DLI. But the most important factor in DLI is the timing. I feel what happens is you have a patient and unless you do frequent MRD assessment or chimerism assessment, if you do let's say every 3 months, you might miss the boat because the role of DLI depends on when you use it. So let's say patient has a fall in T cell chimerism. When you think of DLI, next week give DLI. But if you wait 1 month, 2 months to give DLI, by the time you give, the benefit might be lost. So that's why I feel that the outcome of DLI has not shown as a great benefit like you have seen in CML. So I feel it is the timing or it should be emergent or urgent use of DLI rather than planned DLI. Yeah.
Can I ask one more question, Neeta?
Yes, I think after.
So one question is regarding the children with very high risk AML who have like complex cytogenetics, and sometimes they are very refractory to all the chemo we are using. So in such cases, any role of like venetoclax plus intensive chemo like ida flag or something like that, and your own personal experience and any other strategy when you have failed 2 or 3 lines, how to make them reach transplant?
Great question. And I did highlight few of the things. So first of all, venetoclax. We have been using venetoclax for 4 years or 5 years now. Honestly, it does help reduce the leukemia load. It does not lead to MRD negativity or significant CR like less than 5%. It is that is my pediatric experience. I may be wrong and limited experience because of course you need to have large number of patients. So venetoclax, people are starting to understand there are other biological variables, certain cytogenetic group, and venetoclax doesn't work. For example, NUP98 rearrangement, venetoclax doesn't work. Now we come to know. So I think we will come to know that once we have more data available, that which cytogenetic subgroup venetoclax works. By and large, as long as kid is able to tolerate myeloablative or good dose induction regimen, I would prefer mitoxantrone Ara-C or with high dose Ara-C based regimen. With Flamza is another regimen. And try to reduce the load and go to transplant. Now, going to transplant depends on, of course, your choice and patient's factors, but both RIC and myeloablative approaches are helpful. We have had success using clofarabine bridge as a RIC transplant bridge, and a remarkable outcome in few patients. So we use clofarabine bridge. Yeah.
Thank you. Neeta, you can move to the next session.
Yeah.
Thank you.
We have another 40 minutes left, so let's quickly move to the panel discussion. So we have Dr. Anand as the moderator. He's Senior Consultant, Pediatric Hematology, Oncology and BMT at Sparsh Super Speciality Hospital at Bangalore. And as panelist, Dr. Shah continues, and we have Dr. Pankaj Dwivedi. He's a consultant at the National Cancer Institute in Nagpur. And Dr. Silki Jain, who is assistant professor in ESI Medical College Hospital at Faridabad. And there are some more questions in the chat. I think most of it will be discussed by you in the panel. If there's anything left, we'll take it up at the end. Over to you, Anand.